Welcome, everyone. My name is Jenny Hornick, and I am the Digital Marketing Coordinator here at JMIR Publications. I'm very excited to welcome you all to today's webinar, which is part of our JMIR Mental Health series in collaboration with the Society of Digital Psychiatry. So today's session topic is Smart Apps, Smarter Matches, using sensor data to improve mental health support. I'm going to go ahead and introduce Dr. John Torous. So Dr. Torous is the director of the Digital Psychiatry Division at Beth Israel Deaconess Medical Center, a teaching hospital of Harvard Medical School. He also serves as the editor-in-chief of JMIR Mental Health. So with that, I will pass things over to Dr. Torous to introduce today's speakers and get us started.
Excellent. Thank you, Jenny, and to the entire JMIR team for making this possible with Society of Digital Psychiatry. So today we have an amazing topic to talk about and two amazing speakers. We have Bridget Dwyer and Jane Mikkelson, who are both clinical research coordinators at the Division of Digital Psychiatry at the IDMC. And as we start out this year of webinars, we want to highlight how accessible digital health research is and how these two people who are junior in their careers are doing some amazing, important research. And they're going to share about what they did, what they learned, and where the field is going. So thank you for joining Bridget and Jane. I'm going to drop the link to the paper in the chat. It's accessible and free to everyone. So if you get lost anytime, just follow that paper. But I think where I want to start out is we're going to talk about, there's a lot of mental health apps out there, a lot of health apps anyway. And even if you find a health app, how do you actually stick and engage with it? But let's talk first about just how many health apps do we think exist, maybe just in the mental health space?
So based on our estimates, can you hear?
Yeah.
Based on our estimates, we assume about 10,000 mental health apps, much more actual physical health apps and stuff like that. But in terms of the mental health realm, of course, we haven't been able to count every single one, but we estimate about 10,000, which is, of course, a very overwhelming number, which makes it difficult to navigate the marketplace for users trying to find one that, fits their needs.
I think that is a good estimate, and we have to acknowledge there is no clear definition of what a mental health app is. That could include kind of lifestyle apps, different interventions, but certainly a vast and large number of these apps that exist. And in terms of people want mental health support, they're looking for accessible tools. These apps are advertised directly on social media, especially to younger people. How do we make sense of all these apps today? How do people even begin to kind of figure out which one they may want to use or they don't want to use?
Yeah, so we've collaborated with the American Psychiatric Association to develop our app evaluation framework. And this framework has over 105 different objective questions about different mental health app features, such as presence of a privacy policy, are there journaling features, mindfulness, does it have different clinical value like CBT or something like that. And we've actually translated this framework into our database, mindapps.org, that John just put in the chat, so you can check it out. It's really great to help streamline clinician app recommendations as well as patient basing.
And maybe, Bridget, can you give an example of, there's this website we put in the chat. It has a lot of stuff in it. Like, how do you even use it or approach it?
Yeah, absolutely. So as Jane mentioned, we did develop that framework in conjunction with the APA, but to take it a step further and make it actionable, we essentially translated every question on the framework to a filter on the MindApps database. So if you visit the database, maybe you can pull it up on your computer right now, you'll see on the left-hand side, there's a bunch of different criteria. So things like cost, features, treatment approaches, and basically the idea is that any user can navigate to the website and basically input the criteria that they're looking for. So for example, if I was someone who decided I want to try out a mental health app, however, I don't want to pay for one, I could go to the cost selection, select totally free, so free to download, free to use, and I have a diagnosis of bipolar, so I could put in as supported conditions as bipolar. And also journaling is a coping mechanism that's really helped for me in the past. So I could go under the features mechanism and basically put in those three things, and the database will result back to you the apps that meet your criteria. So you can play around with them. We're still not suggesting that they're perfect, but based on what you're looking for, that's what we have assessed in an objective way, like the app offers.
And as you said, if there's 100 filters or questions for each app, is it private? Does it have evidence? Does it have gamification? It's a lot of combinations to search for. So I imagine you could make, I haven't done the math, but thousands, if not millions of combinations of searches in what to find. And that perhaps brings me, as we move towards this paper, this idea of digital phenotyping, where we're talking about there's a lot of ways to search for an app, what you may want. It's hard to know. What exactly is digital phenotyping? Then we'll tie it together and talk about your study.
Yeah, so digital phenotyping, we use a smartphone app. We have a smartphone app that was developed by researchers on our team called MindLamp, and we use this app to collect active and passive data features to be able to cluster and predict certain outcomes. So in this paper, we used MindLamp to help digital phenotype people by collecting a lot of their active and passive data. So we can add custom surveys into the app, as well as collect those passive data features like GPS, accelerometer, step count, and then we can use those raw sensors to be able to translate them into like actionable kind of clinical outcomes that we can do different correlations and different statistics with to see what that relationship looks like. So like step count and home time, or anxiety and depression and stuff like that.
So would the idea be, let's say I partook in the study, I signed informed consent, I downloaded this digital phenotyping app to my phone. You may get a profile and say, John, your sleep is not so great based on your phone, and your home time is really high, and you're more depressed when you're at home. That means you may really do well with an app that helps you with sleep, home time, and depression. Or we may give it to someone else and they may be like, you're really active and doing well, and this is an app for this. Is that the basic idea of digital phenotyping meets app evaluation?
Yeah, absolutely. So I can talk about it a little bit in terms of the specific study design.
Yeah,
So yeah, as Jane said, the digital phenotyping, we're taking these active and passive features and essentially developing a behavioral profile about someone based on, their interactions with the app and also their self-reported behavior. So basically for our study, it was a 5-week period, and you can go to figure 4 in the paper if you want to follow along. And basically, the first week of the study was completely observational, where 1 week, at the first meeting, we meet with the participants, they download MindLamp, they say yes to all of our features that we want to collect. And for 1 week, they're basically just going about their life, using the app, taking surveys, and it's passively collecting information about their sleep, steps, screen time, stuff like that. And after 1 week, they come back, and this is where the differentiation between the control and experimental group happen. So for the experimental group, this is when we would sit down with them, and it's all virtual. So over Zoom, you sit down with them, and we share our screen to their data visualization. We actually make handouts of the behavioral profile we've created about them. We sit with them and basically say, okay, it looks like, for example, depression was your most prevalent symptom that affected your ability to function in your day-to-day life. And I can go over the correlation matrix and how we did that more specifically later. So we would say very clearly, like, explain to them, they can ask any questions, and we would say, because of this, we are recommending or prescribing this one specific app. In our study, it was an app called How We Feel. And we suggest that you engage with this for 4 weeks because of your depression symptoms, we think that this will help you, basically. And then, so that's the experimental group. And then the control group, we basically give its unguided app selection. So it's meant to mimic, naturalistic engagement and choice in the real world. So we show them a subset of apps, and we're like, choose whatever you want, basically, and use this as you would in your day-to-day life. Like no instructions from us. Like, it's kind of, yeah, as as naturalistic as you can make it in a research study. That's basically what we do. And then for 4 weeks, we continue to track all of their passive and active data to continue to develop that digital phenotyping profile. And at the same time, we're collecting their engagement metrics. So we have different ways of doing that, which I'm sure we'll go into, but basically subjective and objective measures that at the end we looked at, the differences between unguided app selection or naturalistic engagement versus this app prescription method.
So to summarize, everyone in the initial period is collecting this sensor data from their phone. That lets us build a behavioral profile, which is novel. We don't always know what that behavioral profile means, but we try to use that to say maybe your behavioral signals mean you should get this app. And the other group, we say, let's just pick it from the database based on what you want, your preferences. So at the end of the day, it was still people picking the app that they wanted to do. Some people got extra guidance and information for it. And as you allude to, Bridget, we're trying to also see, can we improve engagement? Will people use these apps? We've talked in different webinars that low engagement is in some ways the Achilles heel of a lot of digital health, including digital mental health. And ideally, if we help someone find a tool or an app that's best for them, maybe they would use it more or engage more. But you alluded to this. How do we measure engagement? I think everyone also on this call is probably wondering too, like what does it mean to engage? So let's talk about your kind of interesting methods you use to measure not measure innovation, to measure engagement. Sorry.
Yeah, there's a lot of different ways that we can interpret engagement. So we kind of had 2 sides to this. So we measured objective engagement, objective screen time, as well as self-reported engagement. So how much did you use the app? And then we also had the Digital Working Alliance scale to see how people kind of felt about using the app and kind of their relationship to the app. As we also had a qualitative aspect of the study where we had a final questionnaire where we asked participants, like, did you use the app? Did you like the app? Different questions like that. And we kind of found 3 emerging themes that, like perceived. Yeah, that I
Just
might be
on
getting
the
ahead of
3,
myself.
so objective engagement, how do you get that?
Yeah,
Bridget.
so as Jane said, we collected it in different ways. And as John said, engagement there's no standardized engagement metric. It's still something in the field that's developing when we're learning. And so objective engagement in terms of our study was screen time. So we literally sat down with them at the end of the study and had them send us screenshots of their settings app and saw
So from the
literally
phone
how many
itself.
minutes. What was that?
So from the phone itself, it sounds
Yes,
like.
from the phone
Okay.
itself, exactly, from their own device. Like we taught them to navigate to the settings app, to find the app, to send us images over time. So we did that in terms of objective. And then every single day, they self-reported their engagement with the app on the daily survey. And then at the very end, they took the qualitative survey, as Jane mentioned, where they basically rated their engagement on a scale of 1 to 10 as kind of another metric. And then were provided an open-ended, like qualitative response of like, describe things that had an impact or describe your engagement, which we then assessed at the end. But yeah, I think that there's different, like in different studies, we've seen them measure it so differently, which most studies use self-reported data, which all of the data shows that actually doesn't have real correlation with objective data. Some studies measure it by the amount of modules completed, by the amount of minutes they spent meditating in an app. But then I think the important factor we've realized is like, of course, you can get these objective measures of like even the minutes and screen time that we collected, but does that mean they were cognitively engaged? Were they passively using it? And so I think that that's why it's important, and what we found, that we have both sides, the objective and the subjective, because the participant or the patient perspective on how they were using it can tell you a lot, especially when you combine it with the objective data measures like minutes.
That makes sense. And there's this odd term that floats around the digital health world called e-obtainment. And the idea of e-obtainment is maybe you learned a skill from the app and you stop using it because you got what you wanted. You obtained your goal. So sometimes a more objective engagement doesn't always mean better. And again, sometimes it's important to ask people kind of how did it feel? Was it useful to you? So I think, Jane, this is where you were explaining that we have these different ways to measure engagement. We're not saying any are right, any are wrong, but you've set us up that now we have some people randomized to get kind of more precision guidance on what app to use, some people picking from the Mind Apps database, and you're measuring engagement over time. What are the main results to share? And I think, Jane, you were about to share some pretty interesting ones around engagement.
Yes, yeah. So actually on figure 7 in the paper, if you're following along, we found that mean screen time was higher for the experimental group for those participants who actually did receive that data visualization and received that kind of guidance with the research assistant to kind of personalize that app selection. And we see that engagement did naturally kind of drop over the course of the 4 weeks that participants were using the app, but we see that it started off pretty high and was higher for the experimental group.
One of the interesting results is kind of the correlation between objective use as measured by kind of looking at the smartphone. The smartphone gives us a number of how many minutes was opened, and subjective use, when you just ask people like, did you engage with it? There really wasn't a strong relationship between objective and subjective. What do we make of that?
Yeah, I think that speaks to, I mean, people are unreliable narrators a lot of the time, but that doesn't mean it's not valuable information to collect, because it kind of, as we said, we want to take that combined approach of like understanding their perspective of their engagement and their screen time, as well as the objective features. But it's definitely something we see, in research across the field, that self-report data is largely not trustworthy, but again, just speaks to why it's important to have multiple metrics of measurement.
I think, as you said, it really means you need both, because we said just because you're objectively using it doesn't mean you're using it in a meaningful way. And it may be, if you think you're using it, it doesn't always mean that there's a little bit of both. And I think this is why the research has been so confusing to date on how does engagement matter, because there's many ways to measure it, and there's probably can't just pick one of these measures and say, this is the one that we're going to go with and to use. So I think it's a pretty interesting finding that you need both of them, and you probably need a combination of both of them. In terms of going back to, again, one group, as you were explaining to us, Jane, we used the digital phenotypes were used to kind of guide them and say, this may be an app that's a better measure, better tool for you, and better group didn't get that guidance. And you said the group that kind of got that precision guidance seemed to be a little bit more engaged. Were there any other differences in the group that got that digital phenotyping or precision recommendation that you noticed?
Yeah, so something that I did find interesting, a little bit surprising, was that even though the experimental group did have higher engagement in terms of objective screen time, the control group actually reported higher engagement despite those kind of conflicting results. The experimental had higher, but control actually reported higher. So it's kind of an interesting finding.
Interesting. And clearly, as you outline, we're learning what digital phenotypes are as we capture the sensor information to build behavioral profiles. We don't have a perfect way to match a behavioral profile to an exact app. This was, again, you guys put in some very good theoretical models. You met with a lot of people with experience. We did the best model possible. Looking back, or kind of from all of your knowledge you've accumulated in different folks you've talked with, what digital signal do you think may or may not be useful to guide recommending an app, or are we too early to get this to work at scale? The hard question.
I think that, so I guess, so I can talk about a little bit how we did it in this study So if you go to, let me see, the correlation matrix is actually what we used, which is let me see.
I think it's figure 6.
Yes, figure 6. So if you go to the data visualizations for figure 5 and 6, this is part of what we showed the participants in the experimental group. So the participants who are made aware of, their behavioral profile. So figure 5 is actually, they took a subset of clinical surveys and we kind of explained those to them. But figure 6, what we call the correlation matrix, is how we actually decided what app to prescribe them. Again, we're not suggesting that this is the best way possible, but the pilot nature of the study, this is how we thought we could be the most objective. So essentially, as you can see, the correlation matrix draws correlations between different features, passive and active. And of course, if it's negative, that shows it has, or suggests it has a inverse relationship. Whereas it's positive, it means basically both features are moving in the same direction. So if I was to sit down with a participant in the study, I'll basically just run through what we would do. Is we would always start with, in no way is this a full picture of who you are. This is based off of limited data over a limited period of time over our app. And so, always give that little disclaimer. We would say, but it can be really interesting and sometimes insightful to look at this information and you can see if it resonates with your life. Or with what you've been experiencing. And so for this one, for figure 6, this depression has the most significant relationship because depression and difficulty functioning, let me just pull up the paper. Depression and difficulty functioning have that 0.95 positive correlation. So suggesting that as their difficulty functioning is increasing, so is their depression, or as their depression is decreasing, so is their difficulty functioning, suggesting that might have the biggest impact on their day-to-day life, right? And then, for example, if you look at difficulty functioning and anxiety, it's a little bit lower. It is still an inverse relationship that might affect one another. But in terms of this participant, we would prescribe them the depression app after kind of explaining this to them. So that was the largest signal we used in this preparation, but we definitely learned a lot about, how we might be able to improve that in the future.
And I think what's nice about this approach too is it's very personalized for the individuals. You said we're asking someone, does this resonate with you? What are you seeing? We're not telling someone this is 100% deterministic model of your health based on smartphone sensors. We're saying, look, here's a new view. Does it make sense to you? And let's pick together something that could be useful, because as we know, a lot of these digital phenotypes and digital biomarkers are personalized to different people. Some people may have an association between home time and depression, and it may be opposite for some people, right? Home may be a wonderful environment or it could be a stressful environment. So I think it does make sense to do it on a personal model. And clearly now that the pilot data has been collected, this could be used to find future trends, because you were doing this prospectively. So there could be ways. Before we jump to questions, I also want to jump to the results you have around long-term engagement. So we've really talked about how we can use the digital signals to match to an app. Engagement is hard to measure. Different measures tell us different things. They don't always correlate together. But clearly, part of the study was trying to say, do people stick with an app, and what is kind of that behavioral intention? And I think you guys had some pretty interesting findings to talk about there too.
So that was kind of what I was touching on before with a lot of that qualitative, jump the gun a little bit, but we found 3 kind of main themes that emerged, and you can follow along on figure 9. Bridget made a beautiful figure there. So we can see that something that really came up was perceived therapeutic use. So did they find it useful? Did they find that it had clinical value? A lot of this can be even before they, like, assumptions made about the app, even before they use it themselves. So just looking at like the page on the app, the description, like, does it kind of resonate with them from a therapeutic standpoint? And then another was behavioral use. So we found this definitely at the end of the study. Did they make a habit out of using it? Were they motivated? Did they remember? Was it incorporated it into their routine? We also found that this was kind of like affect dependent. So maybe they said that they like were drawn to the app when they felt down and were able to track their mood and that was helpful. Or maybe they only used it when they felt good and remembered. So that's kind of this like behavioral component. And this is, as we know, like our environments are very dynamic. So a lot of things kind of shape that point for engagement. So it can be really hard to quantify. And then another aspect that we found, another main theme was access and usability. So was the app easy to use? Was it easy to navigate? Were there a million buttons? This kind of accessibility. Was it an affordable option? Was it accessible if they had like no Wi-Fi or something? Or did they even have an app that they already used and liked? And that kind of came up sometimes too. So a lot of different factors that can kind of go into that initial engagement as well as sustained use.
Yeah, it's a whole topic of discussion there that you have on these themes that are so important. And I think we don't quite have time to cover digital navigators in the role that kind of human support, be it people helping people, play in this. But I think it's pretty clear everything we've talked about. It's even the digital signals are about an individual, interpreted by an individual together as a team. Using the app is probably something that can require some support for these themes. It still is about people helping people, despite us talking about these advanced digital signals and phenotypes we can get. So let's switch to questions. I see some in the chat already. This is a good time to add them if you haven't done it. And this is an interesting question saying, how do you think the novelty factor impacts engagement with apps?
I think that, well, as we saw in our data, the highest engagement in terms of objective was the first week, and it really fell off after the first week of data. So I think novelty, definitely, maybe people are excited to use it, people are motivated, definitely at the beginning. And then, as Jane touched on, the behavioral element is what we have seen, so like lays the foundation for sustained use. So I do think novelty has a big part of initial engagement, but it doesn't, obviously, because it isn't novel after you've been using it for time, it doesn't affect it or help it in the long term.
That makes sense. This is a question saying, I'm curious about mindapps.org. Do you know if it will be continuously updated? Apologies if this was answered and I missed it.
No worries. Yeah, so mindapps.org is updated continuously. We have an amazing team of app raters that are constantly going through apps. So you can ensure that all that information is updated every 6 months, I believe, 6 months. And yeah, we have a great team behind MindApps, so we recommend you guys check it out.
Excellent answer. And this question says, is the goal to implement this method in the real world, as we talk about this kind of digital phenotyping matching? What are some of the main changes around that you would, what are some things you may change around this to kind of make sure it can fit into just the busy, hectic world that is people's world, clinical's world? Like, what would we do differently, or do you think it's just ready to go today?
I think definitely not. I think we've learned a lot of insights that we can, bring into the real world. One thing that we know increases engagement is that social or therapeutic support. So in terms of translating it into the real world right now, our team actually does a lot of work around, clinically prescribing, how we can help clinicians facilitate like clinically prescribing apps. We actually just developed a little different version of MindApps that's developed towards clinicians for them to sit down with their patient and really quickly take a quiz and then prescribe an app to them. Anyway, that's separate. But I think the takeaways from this study that show us that patients do engage more if they feel like the app is personalized towards them, if they have human support, and if yeah, sometimes if they get that feedback, which, if you're using it in therapy or with a clinician or with a digital navigator, hopefully you are getting that feedback from the app, and all of that works together to boost engagement.
That makes sense. There's a lot of pieces to it. Another question, what is the main barrier to low usage of digital phenotyping in clinics or clinical practices? So here we're talking about we can use people's own smartphones to collect these behavioral profiles. Why aren't we doing it for everything?
Yeah, so that is definitely a huge issue is the barriers to, getting into digital mental health tools for everyone to make it, feasible for all populations and scalable so we can, share it with everyone. But we found that digital literacy is one of the main barriers. So people lacking essential smartphone skills or laptop skills to be able to even really get started. So we have a really great program called Doors. It's digital outreach for obtaining resources and skills. We kind of have been piloting this in different community organizations as well as the inpatient unit on the IDMC, and we hold different workshops for people to be able to help them navigate their smartphone, as we know that digital literacy is a social determinant of health and really impacts people's ability to engage with different healthcare software, even as simple as like logging onto a patient portal. So I think that a really great initiative, a part of our team, is this digital literacy component, because you can't really address like these really amazing innovative tools without kind of getting to that foundational barrier.
Yeah, and that perhaps leads into the next question of clearly you're helping people find mental health apps who can get to the Mind Apps database. Do we know anything about the people that are going to the database or the users, and what can be done to reach people who maybe aren't aware that these tools exist? And this may relate to what you said around digital literacy training, Shane.
Sorry, could you repeat that
Yeah.
question?
So we have the database, as you said, mindapps.org, and do we know anything about the people who are using the database?
Right, right.
And is there a way to bring new people who don't even know these things exist and help them learn about it?
Yes, absolutely. Sorry about that. Yeah, we're constantly trying to create like a little community network around Mind Apps. We get a lot of clinician interest about, they're saying like patients are asking about mental health apps. How do I kind of help support their selection process? So on mindapps.org, you'll find that there's two different pages, the light and pro version. So light version, we kind of co-designed this with our patient advisory board as well as other patients on the inpatient unit based on their feedback that, 105 filters is a lot of filters with the database. So kind of made a little bit of a more pared down version that's kind of more patient facing. And then we have that pro version where you do need to put in your email to be able to access it, but it's really our way of kind of seeing who's been using it and kind of creating that profile and community for people using Mind Apps.
That makes sense. And I don't think we have data on who actually uses it. The website doesn't collect any information, so it's a little bit of a mystery who's going there unless people reach out to complain or compliment it. Either way. This is an interesting question saying, do you intend to include hardware-based solutions as well on, I think, on the Mind Apps database? So right now, I think it only has smartphone apps, as you guys were saying. Is there a realm where it has virtual reality devices, where it has watches, chatbots?
Yeah, right now it is only mental health apps. We actually have, like, we've worked with different teams to have some physical health apps, like maybe heart rate monitoring, stuff like that. But right now it is just apps. Of course, the future of digital health and digital psychiatry is ever evolving, and AI and chatbots and your AI therapists are huge topics. So right now our team is taking the first steps to assessing, to assessing AI and stuff like that, because we've learned a lot in how to objectively assess apps and how to objectively assess, different interventions in digital health. But of course, we want to be, fully versed and confident in our capabilities, and we never want to get in over our head and make assumptions or provide information to people that we're not aware of. So we're definitely, making our way towards that. We do work in virtual reality and are actually currently translating the Mind Apps framework. So the framework, the questions that we use to assess apps, we're currently translating that to assess AI and the AI therapist, because we think that's where the field's going, and it's really interesting and will be valuable to patients and clinicians because so many people are using it. And the number one priority is, safety and how can, in time, I think we can trust all of these resources, but it's important for us to feel confident, evaluating them and then providing information about them.
That may have been my internet. I apologize. I think maybe we'll do a couple quick fire questions and then try to end quickly. One question is, how do we add apps, or is there a way to suggest or recommend apps to add to mindapps.org?
Yeah, so anyone is welcome to email us. We get a lot of different emails from many different app developers and teams wondering if they can add their app. So basically our process is we'll take a look at your app on the App Store. We'd love to meet with you too if that is something that anyone is interested in. And we basically just go through the whole app evaluation framework with our team of app raters, and we ensure inter-rater reliability for all of our apps. And it's not too much of a process. We have a little bit of criteria. Has to be updated in the last 4 years. Bridget, if you want to jump in with all the other ones, I know there's quite a few.
The 4 overarching criteria are, right now, it has to be, a mental health app of some sort. It has to be less than $10 to download. It has to be updated in the last 4 years, free of any stigmatizing, racist, inaccurate content. And then it has to be accessible to the public. So it can't require like an insurance code only to use it, or, some code. It has to be anyone could theoretically sit down and access this app.
And maybe the last question is, we did talk about engagement and use of the apps. Did we see a relationship between engagement and people benefiting clinically from the apps? And I know the caveat is, you explained to us, sometimes engagement can be high and low depending on how you measure it. But what was your sense of, does engagement impact outcomes? That's our final question.
Yeah. So for the result of our study, we were definitely limited by a small sample size. We didn't see any statistically significant results between clinical survey changes and app use, whether in the control or experimental arm. Because patients in our study or participants took, a slew of like the GAD-7, the social anxiety, all of those scales at week 1, week 2, and at week 5 after, as a baseline and after engaging with the app. So we didn't see any statistically significant clinical changes. However, yeah, that's something in the next iteration of the study we definitely hope to focus on. And yeah.
I think that was a lot of rapid fire questions. So thank you so much. And thank you both for just taking us through this pretty impressive research. I think it also highlights that there's so many open questions in this field, and that there's a lot of avenues for anyone to partake in this. I think having new ideas, new voices makes sense. It's a growing young field, and everyone can do impressive, amazing work and sometimes generate more questions than answers, but that's how we're going to learn. So thank you both, Bridget and Jane. Thank you to the JMIR team and Society of Digital Psychiatry. Until next time, bye.
Thank you so much.
Thank you.